So we have a rehab protocol for posterior instability, which we use. And basically, it's like building a house. First 6 weeks, the foundation of the house goes in, right? Cement gets hard, so you're careful. Next 6 weeks is all about synchronous range of motion, right? 6 weeks of making sure everything in the symphony is playing the right tune. The violins aren't playing something different. Then the second floor of the house, the next 6 weeks after that, is all about strengthening. And we have a protocol for that. And then around 4 months, that's the roof of the house, and that's starting sport-specific activities. And that's how I explain it to them.
I'm here in Nashville, Stephania Bell from ESPN at AOSSM's annual meeting, and I'm pleased to be joined by Dr. Jim Bradley, Professor of Orthopedics at UPMC, that's University of Pittsburgh Medical Center, also the head team physician for the Pittsburgh Steelers, and the past president of the AOSSM. Thanks for joining me, Jim.
Oh, no, thanks for having me. I'm very pleased.
You know, one of the areas of expertise that I associate with you most often is shoulder instability. I've heard you talk about it at different meetings and conferences over the years, and even more specifically, posterior shoulder instability or recurrent subluxation. So what I wanted to ask you is how, in your view, has the surgical management of posterior instability evolved over your career?
Well, a couple of things. We wrote a paper in 1993, Jimmy Boney and I, and we said that in athletes it's more common to have posterior instability than anterior instability. And everybody didn't believe this. So we recently just finished our study of 1,975 consecutive instability cases since 2006 that I've done, and only a third of those are anterior. Everything else is posterior. So when we first started to do that posterior, we'd have to open them up to do them. We'd have to make a split, big incision, open them up, and then we learned with suture anchors and suture kind of these little holes we used to make to reconstruct it. And then all of a sudden arthroscopy came along, and then I was really interested in doing it minimally invasive, so we developed a way to repair the labrum and repair the capsule through sometimes 2 or maybe 3 holes, depending on what type of posterior instability they had. But the problem was the knots. So you had to tie knots, and those knots were abrasive, especially to the rotator cuff. So then, with the help of Arthrex helped me, and we designed different types of anchors, and we used this thing called suture tape, which is polyester in the middle and polyethylene on the outside, polyethylene in the middle, polyester on the outside, because the body does not like polyurethane. It loves polyester, so they'll cover. So now you've got these bands, and then they allowed me to do this study, and the pull-out strength of that construct with these bands instead of sutures was 39% greater pull-out strength. So we changed it. And then what we've done, we've got new instrumentation has come out that we can fix the capsule. So sometimes when people get true posterior shoulder dislocations, you got the capsule's torn too. So in other words, the labrum's torn off and there's a big hole in the capsule. So now we have instruments that we can fix the capsule first and not over tighten it, and then fix the labrum. So it's come full circle now. And you know, it used to take us a long time. Now it's 35, 40 minutes we can fix one of these.
You mentioned the bands that you're using as well. More comfortable for the patient in addition to the pull-out strength being greater? Well,
the problem with the knots were, even though you tied them away from the shoulder on the outside of the labrum, they would migrate inward, and then they'd abrade not only the articular cartilage but the rotator cuff, and the patients would get more symptoms.
Which is undesirable.
Which is very undesirable.
Do you think that now people believe about posterior instability?
Oh, yeah. I mean, in athletes, posterior subluxation of the shoulder in athletes is way more common than anterior stuff, and it's not even close. In the last, there's two more articles that were written. One was written by Javier Duralde for 280 consecutive cases. Most of them were posterior. Ben Kibler, same thing, 169 cases. And then I said, enough of this. We're just going to go back on our database and see how many we had. And so 70% of our athletes had some form of posterior instability.
Even if surgery is indicated, when you're dealing with elite athletes who are in season, there's discussions about whether to do surgery or brace or hold off. How do you have that conversation, and what are your recommendations?
So we get the MRI, obviously, and we'll evaluate that. But most posterior instabilities in NFL athletes or elite athletes I take care of, I can get them through the season. It's not like anterior instability, where posterior instability is much more better tolerated. And they don't get as much arthritis as people with anterior instability. So what I do is I try to get them through the season and then fix them as soon as the season's over. and that's worked pretty well for us.
And what does getting them through the season look like?
Well, there's no really great brace for posterior instability. There's just one. But what we do is we try to make them avoid doing a lot of overhead lifting, bench pressing. We'd rather them doing pec decks. I know there's a lot of physical therapists out there, but no deadlifts, no pull-ups, no a lot of militaries or anything like that. So more stuff in the front in the pec deck, and then just treat them symptomatically until we can get them to the end of the season. Now, if they have a true posterior dislocation, that's totally a different thing. So that means I'm going to fix them right away. I can't wait because there's going to be a hole in that capsule, and if I don't fix it right away, when I do go in at the end of the season, I will over-tighten them, and I can't afford that.
For the recurrent subluxation folks, after they have a surgical stabilization procedure, what does the rehab look like, and how long until they're back, return to play?
Yeah, they rehab pretty well, much better than anteriors in our hands. And we have a rehab protocol for posterior instability, which we use. And basically, it's like building a house. First 6 weeks, the foundation of the house goes in, right? Cement gets hard, so you're careful. Next 6 weeks is all about synchronous range of motion, right? 6 weeks of making sure everything in the symphony is playing the right tune. The violins aren't playing something different. Then the second floor of the house, the next 6 weeks after that, is all about strengthening. All right, and we have a protocol for that. And then around 4 months, that's the roof of the house, and that's starting sport-specific activities. And that's how I explain it to them.
It makes sense to me.
Good.
I'm in a pivot for a moment, and I've heard you talk about the importance of the team, taking care of a team. It's not just the head team physician or the head orthopedic surgeon, it's the whole team. How do you, as the captain of the ship at the Steelers, for example, foster that team culture where everyone recognizes their worth?
Well, let me give you some numbers. When I first started with the Steelers 35 years ago, I had 9 people I had to manage. In 2013, it was 32. Now, at the last time we looked, it was 43 people. So what you got to do is, as the leader, you got to tell them this is a team, and I'm only as good as you all. And I tell them every year, we have a big dinner, and I say we're the Pittsburgh Steelers, and we're expected to be different because we're a model. And Mr. Rooney wants us to be that way. So I pick the right people, and then I engage them all. And I don't let them get away with anything. So I engage them. Like if I don't see they're engaged or they're coming in and not saying anything, I will physically engage them and say, well, what do you think? But we have every subspecialty is covered, everything. OBGYN, plastic surgery, ENT, general surgery. I mean, everything is covered. So I have a go-to guy. And then you don't get to the Super Bowl with a bad sports medicine team. You just can't get there, all right? Because every one of them has helped us in some way to get our team to the Super Bowl. So the one year we went in 2005, Mr. Rooney came up and said to me, do you realize that I have every single player available? Well, that's John Norwig. That's my head trainer. That's Tony Yates. That's my head internist. And it was like a three-headed monster. You know what I mean? We were back-to-back. So it would be me, Yates, and John Norwig. And we just had each other's back, and we made the decisions together. Mm-hmm. There's no eyes in this team thing. It just doesn't work. I mean, I've seen it. This is what I think. If you want to see a good organization, you find the smartest people you can find, and you're not intimidated by them, and you float the boat, right? But there are other people that are leaders that they want to be the kingpin, and they don't want anybody to be able to usurp them. That is a bad way to do it. So I'm a kind of a boat floater guy.
And you got the ring to prove it.
I got a couple of rings to prove it.
All right. Well, thank you very much for taking a few minutes to join me here at AOSSM.
Thank you all. Appreciate you.